আসসালামু আলাইকুম এবং আদাব। আমি ডক্টর দেবেশ। আমি রংপুর মেডিকেল কলেজের 2015-16 সেশনে স্টুডেন্ট। আমি রংপুর মেডিকেল কলেজে 45th ব্যাচ ছিলাম। আমি হচ্ছে 2022 জুলাইতে ইন্টার্নশিপ শেষ করে আমি নেপাল চলে আসছি। তারপরে হচ্ছে আমি ইউএসএমএল স্টেপ 1 দিচ্ছি। এই কিছুদিন পরে আমি স্টেপ 2 দিব। আমি তো হচ্ছে অ্যাক্সিস মেডিকেল এর এই প্ল্যাটফর্মে হচ্ছে আমি ইউএসএমএল রিলেটেড ক্লাসগুলো নিচ্ছি আর কি। তো এখন পর্যন্ত আমি ওরিয়েন্টেশন ক্লাস নিচ্ছি এবং হচ্ছে এখন হচ্ছে কার্ডিওভাস্কুলার সিরিজের ক্লাস চলতেছে। এখানে অ্যানাটমিটা শেষ করলাম, এমব্রিওলজিটা শেষ করলাম, আজকে ফিজিওলজির শেষ ক্লাস। আমি আগের ফিজিওলজির দুটি ক্লাস নিচ্ছি, আজকে তৃতীয় ক্লাসটা হচ্ছে বেসিক্যালি এই এই থার্ড ক্লাস পরে হচ্ছে আমাদের ফিজিওলজি টপিকটা শেষ হয়ে যাবে, তারপর আমরা শুরু করবো প্যাথোলজি। এইভাবে আমরা ফার্মাকোলজি ডিসকাস করব, আর তারপর আমরা কার্ডিওভাস্কুলার সিস্টেম শেষ করবো, তারপর আমরা অন্য সিস্টেমে যাব। তো এটা ছিল আমার প্রোটোকল আর কি। তো আজকে ফিজিওলজি অফ কার্ডিওভাস্কুলার সিস্টেমের লাস্ট ক্লাস। আশা করি যে আপনারা যেখান থেকে শুনতেছেন, আপনারা বাংলাদেশ থেকে শুনতেছেন, না হলে বাংলাদেশের বাইরে থেকে শুনতেছেন, না হলে অ- আরো অন্য কোন দেশ থেকে শুনতেছেন, আমার এই স্লাইড গুলো আপনি দেখতে পাচ্ছেন এবং আমি যে বলতেছি ওইগুলা আপনার আপনার ল্যাপটপ না হলে মোবাইল পর্যন্ত স্পষ্টভাবে ক্লিয়ার ভাবে চলে আসতেছে। আহ উম, তো আজকে সেশনটা আমি স্লাইডটা শুরু করি। আপনারা জানেন যে আমি কার্ডিওভাস্কুলার সিস্টেম এখন এখন এই টপিকে আছি। আমরা অনেক জিনিসগুলো ডিসকাস করছি, আমরা প্যারামিটার্স গুলো ডিসকাস করছি, আমরা কার্ডিয়াক সাইকেল ডিসকাস করছি, আমরা প্রেসার চেঞ্জেস ডিউরিং কার্ডিয়াক সাইকেল ডিসকাস করছি, আর আমরা হার্ট সাউন্ডস গুলো ডিসকাস করছি, আমরা হচ্ছে ম্যানুভার্স গুলাও ডিসকাস করছি, কখন কোনটা করলে বাড়ে কমে। এ, আজকে হচ্ছে আমাদের অ্যাকশন পোটেনশিয়াল। আজকে এটা হচ্ছে আজকের ক্লাসটাও খুবই ইম্পর্টেন্ট। USMLE থেকে এই কনসেপচুয়াল কোয়েশ্চেন এই টপিক থেকে অনেক আসে। So today we will be discussing about action potential of heart, that is action potential that's going inside heart. Basically, when I have to talk about action potential which is going inside heart, there are two different kinds of action potentials which prevail in heart. The first of its kind prevails in ventricular or cardiac myocytes. And third and second of its prevails in AC node and AV node. So first of all, আমি আগে কার্ডিয়াক মাসলস এর অ্যাকশন পোটেনশিয়াল গুলা ডিসকাস করবো আর কি। তো আশা করি আপনারা এই স্লাইড দেখতে পাচ্ছেন, আমি শুরু করতেছি। তো now we are going to discuss about action potential that takes place in cardiac myocyte. uh, these action potential which take place in cardiac myocyte, it has been divided into 5 phases. They are phase 0, phase 1, phase 2, phase 3, and phase 4. These phases are quite clear in the diagram. I will be describing the events that happens in these phases separately, turn by turn, one by one. So, so we are talking here we are talking about cardiac myocytes. Now, let's talk about resting potential of cardiac myocytes. It's around minus 85 millivolt. This is when the cardiac muscle rests, or this is when the cardiac muscles are not stimulated. So, like we are sleeping, we are resting. In the same way, when cardiac muscle rests or sleeps, it remains at the state of minus 85 millivolt. Slowly, it gets stimulus. When it gets stimulus, sodium channel opens. So here you can see here this green arrow. So sodium channel opens, and this leads to influx. You know, the predominant cation present extracellularly is sodium. So sodium goes in. Due to influx of sodium inside cardiac myocyte, this action potential rises from minus 85 millivolt up to around near about plus 20 millivolt. So this is phase 1. So phase 1 টা basically opening, এটা হচ্ছে due to opening of uh, voltage gated sodium channel, which leads to rise in action potential up to the extent of plus 20 millivolt. This was phase 1. Now let's come to sorry, this was phase 0, which is denoted by this green line and this green arrow, sodium going in. inside the cardiac myocyte. Now let's talk about phase one. In phase one, voltage gated sodium channel closes and potassium channel opens, due to which the intracellular rich potassium environment, it forces potassium to go out, due to which now the action potential of heart falls from this point, or from plus 20 millivolt to near about zero again, or slightly higher than that. So this was the phase one. Now let's come to phase two. Phase two is also called as plateau phase. At this point, uh, there's a kind of flat. This is not exactly flat, but theoretically speaking, there's occurs a kind of flat phase. It's called plateau phase. It occurs due to net effect of potassium out migration and calcium in migration. Here, calcium channel opens, due to which the calcium channel migrates inside, and the potassium channel, as it was previously going out, like that of phase one, it continues to do the same in phase two as well. So combined action of potassium efflux and calcium influx will result in plateau phase. It's called phase two. So here, basically, if calcium ion goes inside, it also triggers the release of calcium ion from sarcoplasmic reticulum. It's called calcium stimulated calcium release, or also called as calcium induced calcium release, due to which there's a kind of positive chain reaction occurring in increase of intracellular calcium. So this is really necessary for extra excitation contraction coupling. Now after this, there's now when this phase two gets over, now there occurs phase three. Phase three is actually the repolarizing phase. Phase zero was a depolarizing phase. Phase one was a kind of repolarizing. Then phase two was plateau. Again, phase three is repolarizing, just like that of phase one. Again, in phase one, now the calcium channel closes and only potassium channel opens. Now potassium channel goes out, and it reaches the resting potential. Now in resting potential, the resting potential is maintained by sodium potassium channel, which creates a balance between uh, potassium influx and sodium outflux, creating this resting membrane potential, maintaining this resting membrane potential. So this was all about action potential of cardiac myocytes. Let me talk about this again in brief. First of all, we have here we have a resting potential. It's about minus 85 millivolt. Cardiac muscle gets stimulated by the external stimulus. Then we have opening of sodium channel, due to which there is in-migration, influx of sodium channel inside the cardiac myocyte. This is called rapid depolarization, which is represented by this green line, also called as phase zero. Now the sodium channel closes, now potassium channel opens, then there is efflux of potassium ions. This is called repolarization. Again, we have phase two. Phase two is plateau phase. It happens due to combined effect of influx of calcium and efflux of sodium. Again, when calcium channel gets closed, we again have another repolarizing phase, just like that of phase one, where potassium channel remains open and potassium channel keeps on going out, as there is efflux of positive ions out from the cardiac myocyte. The action potential falls and slowly it reaches the baseline. It's called, this was phase three. Now we have phase four, the baseline phase. It's called phase four, and phase four is also called resting potential. And here the membrane is quite permeable to potassium. Here potassium comes in and sodium goes out, but sodium potassium pump ensures that the neutrality is maintained, and again heart remains in resting membrane potential. So this was electrical activity that happens in all the cardiac myocytes, except in that of SA node and AVE node. Also, we have let me talk something about this play to phase. This play to phase is peculiar characteristic of ventricular um, muscle action potential. It does not occur in any other places, like it does not occur in neuron or skeletal muscle or SN or AV node. This is all due to combined effect of calcium and potassium. Here, calcium first of all comes in through opening due to opening of calcium channel. Then this new influx of calcium, it stimulates further release of calcium from sarcoplasmic reticulum. So this is called calcium induced calcium release. It causes excitation, contraction, coupling, and causing cardiac muscles to contract. So this was all about action potential of cardiac myocytes. Let's jump to action potential of SN node. SN node, action potential of SN node is quite simple in comparison to ventricle action potential, because there is nothing called play to phase. Here we have phase 0, phase 3, and phase 4. We don't have phase 1 and phase 2. So in phase 0, L-type calcium channel opens, due to which there occurs in-migration of calcium channel. Now again, I would like to stress on some point. Here we can see that resting membrane potential was 85. Now, but in case of SNO, the resting membrane potential is just around 60 millivolt. So it's quite easy. This is the reason for which, like, this is the reason why SC node is easily stimulated, and it can generate its own rhythm, and ventricles cannot generate its own rhythm because they have very low resting membrane potential. Whereas for SC node, resting membrane potential is high in comparison to that of ventricular muscles. That's why they show the property of automaticity. Mm. Now let's talk about phase 0. This phase 0 is the first phase of action potential. In this phase 0, L-type calcium channel opens, due to which that is voltage gated calcium channel opens, and due to which the calcium goes inside the SA node, and this results in rise of action potential up to the range of plus 20 millivolt. And again, um, after this, the phase 0 gets over. Now we have phase 3. During this phase 3, potassium channel opens, and again, potassium channel escapes out of the SA node cells, due to which the action potential again falls. And now, when it reaches at this point that I am pointing with the help of my cursor, here potassium channel closes. Now this is phase 4. Phase 4. In this phase 4, this red line is phase 4. You can see this line here, as well as some portion here. So this phase 4, it's called funny current, and it happens due to net migration of sodium. It happens due to net migration of sodium out of cells and potassium inside the cell. So there's gradual more influx of potassium and less influx of sodium. That's why this phase 4 is gradually rising from -60 to -40. So -40 is threshold limit. From this point, SA node can be stimulated. So this funny current is really necessary or really essential to achieve potential called threshold potential. And from this threshold potential, SA node can easily be stimulated, so that it can carry out another cycle of action potential within itself. This was all about SA node. Now let's come to conduction pathway. I have already talked about. So this was the so this phenomenon, I have only mentioned about SA node, but this phenomenon also occurs in AV node. So this is action potential for both SA node as well as AV node. Now let's come to conduction system of the heart. In conduction system of the heart, we have SA node, internodal pathway, then AV node, bundle of His, right and left bundle branch, and Purkinje fiber. Again, let's talk in detail about those points. SA node, it's situated at the junction between inferior vena cava and right atrium. From this point, this is the point of impulse generation for cardiac cycle. This is the initial point of generation of impulse for entire cardiac cycle to happen. So that's why this point is also called as pacemaker. From this point, pacemaker, cardiac impulses are being generated, and it's being transmitted down to AV node through interneural pathway. There are three interneural pathway: tract of Batchman, tract of von Quebec, and tract of Thorel. Mm, So after after the impulses pass through interneural pathway, it comes to AV node. Again, from AV node, we have bundle of His. Bundle of His again gets divided into right and left bundle branch. Right bundle branch again gets divided into anterior and posterior fascicle. Sorry, left bundle branch again gets divided into left anterior and left posterior fascicle. And finally, all of them branch into fine conducting fibers called Purkinje fiber. Now, let's talk about impulse generation rate of all these points. Here in SNO, the impulse generation point is 60 to 100 beats per minute. For AV node, it's around 40 to 60 beats per minute. For bundle of His, it's around 15 to uh, 15 to 40 beats per 15 to 20 beats per minute. And for Purkinje fiber, it's 5 to 20 beats per minute. And the conduction velocity is maximum in Purkinje fiber. So the rate of impulse generation or rate of acting as pacemaker is highest in SC node, whereas the rate of conduction or velocity of conduction is highest in Purkinje fibers. Now let's correlate the cardiac cycle that we previously studied with ECG. In ECG, we have P wave, QRS complex, and T wave. Also, we have some other important parameters called as PR segment, ST segment, QT segment, and QT segment and QT interval. Sorry, QT interval, QRS interval, PR interval, um, and J point. Let me discuss about all of these in detail. P wave, it represents ventricular depolarization. That is, I'm really sorry. P wave, it represents atrial depolarization. That is atrial contraction. Now, after atrial contraction, we have ventricular contraction. QRS complex represents ventricular contraction. And again, we have T wave. T wave represents ventricular relaxation or ventricular repolarization. Now we have now we have a PI interval. The normal value of PI interval is 3 to 5 small squares. And if we denote it in milliseconds, it's around 120 to 200 milliseconds. QRS interval, the normal value of QRS interval is 3 small squares. There's a point, a junction between QRS complex and this ST segment. It's called J point. Uh, we will study about significance of this ST segment and QRS complex in days to come when we discuss about pathological changes that occur in ECG. For the time being, we will only discuss about um, the significance of physiological significance of these things. Now let's talk about U wave. U wave is something unusual. It only occurs in hypokalemia. It doesn't occur in physiologic states. So in physiologic states, we have P wave, QRS complex, and T wave. So P wave represents atrial depolarization, QRS complex represents ventricular depolarization, and T wave represents ventricular repolarization. Now you may ask, which part of ECG represents atrial repolarization? So that's atrial repolarization is merged with QRS complex. So now also I guess you all know that this small square makes up 0.04 second, and 5 small squares at 5 millimeters represents 0.20 seconds. So we will be using these principles in days to come to calculate rate and rhythm of the heart. Also, we will be using these uh, concepts to study about different pathological abnormal changes which occur in ECG during different states like myocardial infarction and then other rhythm abnormalities. So that was all here about that was all about conducting system of the heart and electrocardiogram. Now let's talk about baroreceptor and chemoreceptors. Now we all know that blood pressure is being regulated in our body. If it becomes high, then there are some certain mechanisms by virtue of which the blood pressure is brought back to normal, and vice versa. If it becomes low, there are some mechanisms by which blood pressure is maintained back to its normal level. So let me first of all talk about receptors. We have two kinds of receptors here. They are baroreceptors and chemoreceptors. Mm, mm, so first of all, let me talk about peripheral receptors. Again, on the basis of location, we have two kinds of receptors. There are central receptors and peripheral receptors. First of all, let me talk about peripheral receptors. The main centers for peripheral receptors, first is this aortic arch here, and second is carotid sinus or carotid body. So in both of these areas, we have got aortic baroreceptor and aortic chemoreceptor, as well as um, carotid site. At the site of carotid bifurcation, we have carotid sinus baroreceptor and carotid body chemoreceptor. So carotid body and aortic arch, these two are the site for peripherally situated chemoreceptors and baroreceptors. So now I have discussed about the location. Let me discuss about the efferent pathway. Um, Impulses or signals from body, aortic body is carried by vagus nerves towards the solitary nucleus of medulla, and same thing happens from this carotid body as well, but the nerve that carries efferent impulses is different. It's glossopharyngeal, which carries impulses, efferent, efferent impulses from baroreceptors and chemoreceptors up to the solitary nucleus of medulla. So that's glossopharyngeal now. Now we have another set of receptors. It's called um, central receptors. We will be talking about that at last, but first of all, let's talk about peripherally situated baroreceptors and chemoreceptors. So the main job of chemoreceptors um, is to sense partial pressure of carbon dioxide, partial pressure of oxygen, and amount of H plus, which is prevailing in blood. Whereas the main job of baroreceptors is to sense pressure increase or decrease, which occurs within the closed system of blood vessels. Now let me discuss about the mechanism by which chemoreceptors work. So we have chemoreceptors at two sites. They are at carotid body as well as they are at carotid body as well as aortic body. So whenever there is increase in partial pressure of carbon dioxide, or decrease in partial pressure of oxygen, or decrease or increase in or decrease in pH, that is when the blood medium gets shifted towards the acidic side. That is um, when it gets deranged from normal pH is 7.35 to normal, so 7.45. If it falls below 7.35, then here we have those peripheral chemoreceptors that are situated in carotid body and aortic body. They get stimulated, and they send afferent signals via their respective nerve fibers, uh, aortic body and carotid body. They send their impulses, efferent impulses via vagus and glossopharyngeal nerves, respectively, towards the medulla. And again, from medulla, we have here there's some kind of processing going on brain in the brain. Then it sends other efferent impulses um, through sympathetic chain, and it causes um, some respective changes that is deployed to neutralize the previously existing hypoxia and hypercarbia. So it stimulates respiratory center to throw out carbon dioxide by means of hyperventilation, as well as taking more oxygen. Again, let me talk about central chemoreceptors. Central chemoreceptors, which is situated in brain, they are stimulated by pH change and or change in partial pressure of carbon dioxide. Now let's talk about baroreceptors. Whenever baroreceptors, they are again situated two peripheral baroreceptors, which are situated in aortic body and carotid body. Whenever there is uh, whenever there is hypotension or decrease in blood pressure, so these decrease in blood pressure, they are sensed by aortic baroreceptor and carotid baroreceptor, and then they send necessary efferent impulses via vagus and glossopharyngeal nerve respectively. Aortic sends by vagus and carotid body sends by carotid baroreceptor sends by glossopharyngeal to medulla. Now from here, as the blood pressure was low, it from medulla there's some kind of processing, and again after that processing, it sends um, sympathetic impulses via efferent pathway, which in turn causes rise of blood pressure as well as increase in heart rate. So same goes when blood pressure gets elevated. When blood pressure gets elevated, the efferent pathway conducts the information or message to medulla, and again from medulla, parasympathetic fibers, parasympathetic nervous system are stimulated, and sympathetic nervous system is shut down, causing a decrease in heart rate, and uh, it also causes vasodilatation that decreases the blood pressure. So whenever the so in short, if I have to say, whenever the blood pressure falls, it's detected by baroreceptors situated at aortic and carotid body, and it um, takes FN impulses via vagus and glossopharyngeal respectively to medulla, and then medulla stimulates as sympathetic nervous system and deactivates parasympathetic nervous system, causing increase in heart rate and increase in blood pressure. It also causes vasoconstriction, and the opposite happens for when there is um, decrease in blood pressure. Sorry, when there is increase in blood pressure. So at that time, the medulla will be sending information to shut down the parasympathetic nervous system and turn on the sympathetic nervous system to increase blood pressure and heart rate. So that was all about blood pressure regulation, which occurs by means of um, centrally situated and peripherally situated baroreceptors and chemoreceptors. Now let me talk about pressure in different chamber of the heart. The basic point of this was to discuss about pulmonary capillary waist pressure. So pulmonary capillary waist pressure is nothing but it's basically a representation of left atrial pressure. Left atrial pressure, it's around. So here you can see here this is left atrium. So pressure of this chamber, it's called pulmonary capillary waist pressure. The normal value of pulmonary capillary waist pressure is between 4 to 12. It lies from 4 to 12 millimeter of mercury. So generally, pulmonary capillary waist pressure is less than left ventricular pressure, except during the time of mitral stenosis. Pulmonary capillary waist pressure is measured with the help of um, Swan-Ganz catheter, which is inserted here by means of the vessels, and it measures manually the pressure that prevails in this chamber. Now let's talk about auto-regulation. Auto-regulation is an important mechanism. By the virtue of auto-regulation, the flow of blood to different organs is maintained, and a kind of homeostatic environment is maintained. Mm, mm, the maintenance of homeostatic environment is very much essential in sustaining our internal environments. Whenever there is any derangement of homeostatic systems, it leads to different imbalances inside our body. So let's talk about auto regulation. Let me tell you a general rule that hypoxia in lungs causes vasoconstriction, whereas it's opposite for all other organs. Hypoxia in other organs causes vasodilatation, whereas in pulmonary vasculature, hypoxia causes vasoconstriction. So the major, uh, that's the main concept which we should be keeping in our mind. Mm, Now let me tell about the advantage of vasoconstriction that occurs in pulmonary vasculature due to hypoxia. Whenever hypoxia occurs, there occurs vasoconstriction in lungs, and due to this, the um, blood vessel gets shut off in poorly ventilated areas, and blood vessel increases in highly in areas which is ventilated more, or which is well ventilated. So this leads to conservation of, like, this leads to effective gases exchange. So that's why the pulmonary vasculature gets constricted or due to hypoxia. This is also the main cause why there occurs pulmonary hypertension due to sleep apnea or obesity hyperventilation syndrome. Prolonged hypoxia in pulmonary vasculature may cause increase in pulmonary hypertension. Also, let me talk about the autoregulation of other organs. I have talked about lungs. Here, hypoxia causes vasoconstriction. Now, let me talk about heart. In all other organs, hypoxia causes vasodilatation. This is due to this is because the body has to increase the blood supply to supply more oxygen towards vital organs. For example, in heart, here, local metabolites like mm, carbon dioxide and oxygen. If carbon dioxide if oxygen decreases, or if carbon dioxide increases, or if then it causes vasodilatation. Also, nitric oxide will cause vasodilatory effect. Also, same with brain. The blood autoregulation of kidney depends on myogenic stretch. It's mainly it mainly leads to activation of renin-angiotensin aldosterone system whenever there is decrease in blood flow to kidney. Also, for skeletal muscle, vasodilatation occur whenever there is increase in uh, carbon dioxide or H plus or adenosine or lactate or potassium. And in skin, we have the main mechanism which prevails in skin is that sympathetic activation causes vasoconstriction in skin, and it causes vasodilatation in muscles. This is due to this is because the body has to preserve uh, its blood flow, and it should increase its blood flow towards muscles, skeletal muscles, which will help us to react during fight or flight mode. Also, another main reason for this is for temperature control. Body does not want to lose more temperature during, like, body does not want to lose, body is not supposed to lose energy in form of heat loss during fight or flight mode. That's why there is sympathetic vasoconstriction in skin. So let's move on to another slide. Now, this is the last topic which we discussed today. It's all about net movement of fluid across the capillary or vessel wall. Now let me give you a concept. There's a force. There, there there are forces which are collectively called Starling forces. So net effect of Starling forces determine whether the fluid goes out of the capillary or comes into the capillary. So um, so the forces, there are four kinds of Starling forces. uh, two kinds of Starling forces. They are responsible for inward movement of fluid into the vessel. That is, they help in retaining fluid inside the vessel. Whereas other two kinds of forces, they help in migration of fluid out of the vessel. So, first of all, let me talk about the two kinds of Starling forces that are responsible for inward movement of fluid into the vessel, or they help in retaining fluid inside the vessel. These are mm, these are oncotic pressure of plasma protein inside vessels and hydrostatic pressure of interstitial space. So hydrostatic pressure of interstitial space, which is represented by uh, pi, and mm, oncotic pressure of mm, plasma protein, which prevails inside vessels. It's represented by mm, uh, this pi c. So these two forces, they work to push fluid inside the vessel. Again, other two kinds of fluid which works to push fluid outside the vessel. They are hydrostatic pressure inside the vessel. The hydrostatic pressure inside the vessel always tries to push fluid outside the vessel wall, whereas another force called plasma mm, uh, oncotic pressure of protein in interstitial space. It draws fluid out from the vessel. So, so if I have to say PC, that is PC, which means hydrostatic pressure inside capillary, and uh, and lambda C. Uh, uh, PC and uh, lambda I. And these two parameters, PC means hydrostatic pressure inside capillary, and lambda I. Lambda I means colloidal osmotic pressure of interstitial space. These two, PC and lambda I, these two parameters, they help to draw fluid out of the vessels. Whereas PI, that is hydrostatic pressure of interstitial space, and um, lambda C, which is colloidal pressure of plasma oncotic pressure. These two forces, they tend to push fluid or retain fluid inside the vessel, or they tend to increase the volume inside the vessel. So, whenever so if we have to denote all these forces in one equation, so there is net fluid flow, that is KF. KF stands for vascular permeability, is PC minus PI. PC stands for hydrostatic pressure inside capillary, minus PI. PI stands for hydrostatic pressure in interstitial fluid, minus this sigma. Sigma is reflection coefficient, that is its resistance to plasma protein flow, minus and then we have pi c. Pi c is colloidal osmotic pressure inside blood vessel, and pi I is colloidal osmotic pressure in interstitial fluid. So this is the equation which helps in determining net fluid, if the fluid is coming into the vessel or going outside the vessel. So that's all for today. So balance of all these starting forces, that is um, hydrostatic pressure of blood inside the vessel, and then hydrostatic pressure of fluid in interstitial space, and then colloidal osmotic pressure of blood inside the vessels, and osmotic pressure uh, in interstitial of interstitial fluid. The balance between all these forces, these are called starting forces. So balance between all these forces will help to determine whether the fluid is being moved out or moved into the vessel. So as a general rule, there's net migration of fluid outside this vessel, which exudates as lymph, and then that excess fluid or lymph is carried by lymphatic pathway to lymph nodes, and from lymph nodes it gets pumped to cisterna chyli, and finally that drains into superior vena cava at the junction between right and left brachiocephalic vein. Now let me talk about some of the causes, like some of the defects in mechanism which causes edema. So for edema, it may be either caused due to increase in hydrostatic pressure of um, capillary. For example, it occurs in heart failure, or it may occur due to a decrease in plasma oncotic pressure. which may occur in hyperproteinemia due to any cause like nephrotic syndrome or any protein losing enteropathy or some other causes. And also uh, mm, there may be uh, also edema is caused due to increase in oncotic pressure of interstitial fluid, which may be caused due to lymph edema. And lastly, we have um, the fourth cause which causes edema is increase in vascular permeability, which occurs during burn or due to effects of toxins or due to effects of um, some other insults, vascular insults. So, so this was all for today. আমি আশা করি যে আজকে এই ক্লাসটা যেটা নিচ্ছি এটা আপনাদের ফ্রুটফুল হচ্ছে এবং হচ্ছে এই টপিক গুলা থেকে অনেক কোয়েশ্চেন গুলা আছে। হোপফুলি আমি কনসেপচুয়াল হিসাবে ক্লিয়ার করার চেষ্টা করলাম আর কি। লাস্টলি আমি হচ্ছে অ্যাক্সিস মেডিকেল ফ্যামিলিকে ধন্যবাদ জানাতে চাচ্ছি, আমার কৃতজ্ঞতা জানাতে চাচ্ছি আমাকে এই অপরচুনিটি দেওয়ার জন্য যে আমি আমার এই নলেজ গুলো এখানে আপনাদেরকে দিতে পারবো। এবং আপনাদের সবাইকে অনেক অনেক ধন্যবাদ আমাকে এই শেষ পর্যন্ত এভাবে পেশেন্টলি শোনার জন্য। আই হোপ আমার এই লেকচার, আমার এই ক্লাসটা আপনার জন্য ভালো এবং লাভবান হয়েছে। থ্যাংক ইউ সো মাচ, থ্যাংক ইউ।